Well, good afternoon to all participants and welcome to this last of 10 in a special series of COVID-19 webinars by the University of Trinidad and Tobago, UTT, presented by Dr. Nicole Ramlachan, Associate Professor, Biotechnology at UTT. Now, the topic this afternoon and focus is hype or hope, investigating the COVID-19 vaccines, vaccine myth and misconceptions. I'm Stephen Cummings, and I will be your moderator for this hour, interactive session. And a little about me: I'm a senior broadcast journalist by profession with some 22 years of professional working experience in the field of media and communications. Worked with both the public and private sector as an advisor in program and events planning. There's lots more that I can say, but this evening is all about COVID-19. Just some quick technical housekeeping, though, to participants. Once you are not speaking, if you are allowed to make a presentation, maybe verbally, you're kindly asked to keep your microphones muted so as to avoid unwanted noises, signals, what have you, that can affect the quality and flow of our program this evening. Also, feel free to post your questions via the platform provided. As many as possible, we will try to respond within the time allotted. So much has been said, about this COVID-19 virus and what it is and what it isn't. Now, during this session, we also hope to deal with some of the clinical aspects and practicalities surrounding the virus and more. In the interest of time, though, it is my pleasure to present and introduce to you Dr. Nicole Ramlachan, Associate Professor, Biotechnology, UTT, who momentarily will make a special presentation and will be available to answer and field questions from participants thereafter. Now, Dr. Ramlachan holds a PhD in genetics from Texas A&M University, USA, and a BSc and MSc from the University of Guelph in Canada. She has extensive experience in research in the areas of genetics, especially in the areas of immunogenetics, clinical genetics and genomics, bacterial and viral biotechnology. Now, she is also involved in genetic testing locally, including SARS-CoV-2 testing and research. Now, I present to you Dr. Nicole Ramlachan to make her presentation, Hype or Hope, investigating the COVID-19 vaccines, vaccine myths and misconceptions. Dr. Ramlachan, it's over to you.
Hello, everyone. Thank you for joining us on this lovely rainy day. I guess, most of us are at home, so I guess it's good that it's rainy. If we're on the road, then it's bad that we're rainy. But if you're looking at me, that means that you're safe at home, I'm safe and sound. So thank you so much, Mr. Cummings, for that wonderful introduction, and thank you for being with us. We hope to have some really good discussion. The format of this one is a little bit different. I'm still doing slides, but we're doing myth busting. So it's going to be less factual in terms of graphs and those kinds of things, and more in terms of really what people's questions have been over the course of doing these little info sessions, as I call them. People have reached out to us and asked kind of, you wouldn't believe the range and the gamut of the questions we've had. And so anyway, you will believe now, because I'm actually answering some of them publicly, right? So we decided to do this to kind of end it off, because it's been a long haul. We've been doing this since April 2021, and we've had a lot of really good input and people who've been excited with what we've been doing. And I wanted to kind of get into the nitty-gritty of the hyper information that's out there, some of which is just totally out of this world, and some of which is is true. So really what we want to focus on, I should say, today is how do we determine real from fake, right? So when people say they do research, for example, I sometimes wonder whether or not they believe that they are truly researchers in the scientific standpoint, because if you compare somebody who sits in front of a computer and does YouTube and look at Instagram influencers and so on, and just random people who have no scientific basis, that is truly not research. That is literally just looking at things on the web. And so there's a difference between actual research, where you're gathering scientific published peer-reviewed data that's published and actually present on the internet, just like any other data, but you have to know where to go and where to get it, right? So people like me do that for a living. Well, we do it for fun too, most of us, but generally I'm lucky enough to be able to do it for a living, which is great for me because I love genetics and I've been doing it for 25 or so years. And I'm so glad to be able to reach out to the public and help you understand a lot of these concepts that are more difficult to understand, right? So what we're doing is we're trying to determine real from fake, especially when it comes to COVID-19 vaccinations, and going through the major things. So I always start with this chain of infection because, I'm a professor at heart, and I would like people to understand exactly what happens when COVID-19 appears. So I usually have a little glib before blurb in terms of how COVID-19, SARS-CoV-2 came to be. But generally, the reservoir changed is really what it is. So it went from an animal virus into a human virus and jumped species. And when that takes place, it allows for replication in an area where it never was before. So what it has is a perfectly immune naive population has never before seen this virus, and therefore the virus is free to just basically run rampage through the population of these particular hosts. In this case, of course, we were unlucky enough that it jumped from a bat host into a human adult host. And later variants, of course, have been mutating to become more able to attach into children and younger adults, right? Which hasn't happened in the past, but now we're seeing that with Delta and some of the other variants. So the reservoir is important. We have to be able to identify the reservoir. The other thing is the portal of exit. How does it leave the body? We know it's the mouth and nose generally, through talking, sneezing, coughing. Mode of transmission, person to person generally, airborne, it stays airborne and can be in isolated particles up to 6 to 8 hours, which we've known for most respiratory viruses, and this is a respiratory virus, so it follows the same etiology. Also direct contact with the virus on a contaminated surface, and of course, person to person directly, right? Portal of entry, of course, same way, mouth and nose right here. And most importantly, the host has to be susceptible, i.e. Immune naive. And for that to occur, for this to keep on happening over and over again, and that virus spreading, replicating in that non-immune person who is susceptible and creating more and more variants and so on, and passing it on and transmitting, and thereby continuing the chain of infection of COVID-19. In terms of what's happening in Trinidad and Tobago, we are 30% peak and falling right now. However, we're still bumping around pretty high in terms of numbers. We've lost roughly about 30%, as I said, of our previous peak, but we have on average, 7-day rolling average, about 161 new infections every day. In total, there's 33,920, but I heard there's more now in terms of what just came out at 4 p.m. I didn't get a chance to look at it. I don't know if you have those numbers, Mr. Cummings.
Yes, we had 5 deaths and 137 new infections.
Right. So
that's of 4 p.m. today.
As of 4 p.m. today, right. So we are coming down in terms of number of daily infections, but if you notice here, our daily deaths are not really coming down as fast as we'd like to see, right? Our 7-day rolling average is a little bit high, which I'll come to shortly. I also want to look at this. The total number of deaths in the world right now as of today is 4 million. So we've already crossed 4 million, which again, pretty high. Our total number of worldwide cases is 185. Totally in Trinidad, we have 33,920 plus whatever was released today, and a little over, I guess, 925 or so deaths, right? In terms of the number of deaths. If we look at the countries basically in our region here, we would note that Colombia and Argentina are quite high in terms of number of 7-day rolling average COVID-19 cases per million. That's how we compare it. We have to compare per million because otherwise you're not going to get a good enough image of what's occurring across the world.
So is that, Doctor, is that per million per population?
Per
I just
million.
want to get
Per
that.
million. It's
So
just
just
per
per
million.
million.
Yeah,
Okay.
straight up per million.
Okay.
So here's Colombia. This one here was kind of peaking above 600 or so. They're now on their way down, as is Argentina. They peaked a few months ago, well, not a few, in May, right around over 700. It was having a huge outbreak. Sorry, I just have to go back. Why am I not going back? Right. And then the United Kingdom, if you notice, is on its way up, right? Kind of, they're having a little bit of an exponential outbreak, and that's because of the Delta. St. Kitts, Nevis also had a little bit of a, well, not a little bit, that's a huge surge a few weeks ago, early June, but they've since come down. And Trinidad and Tobago has been bumping around, right? We had a high of close to 400 in about May 28th or so, and we're now right about just about 100. Guyana is right below us. And if you look at the ones that are basically nil, United States, France, India, Canada, and Germany. So India has actually come quite down. I shouldn't say nil, but low. It's 30.84 to it right now in cases. Canada is 12.46. Germany is 7.44, right? But as I said, UK is one of the ones in the Europe that's increasing. Colombia and Argentina is coming down. Peru in our area is increasing as well too. I didn't include that here because it actually would have made the scale really, really high. That's how bad their numbers are. As is Bahrain a few months ago, but Bahrain's come all the way down now. So again, it's happening in different little epidemics. It's happening around the world, depending on what's happening in that particular area and region because of the variants, right? If you look at the deaths now, it gets a little more interesting. You would notice that Trinidad and Tobago at its highest in terms of deaths per million was actually higher than Argentina, right? Just higher, almost 12, and way higher than India. And India was one of those countries that were seeing hundreds of bodies piled up in these pyres, burning in these parking lots and so on. And it was very, very disheartening and horrible to watch. Now, we don't have those numbers, but in terms of bodies, however, we had a very, very high rate of deaths per million increase. And we also had, if you look from the difference from April to June, it literally was an exponential increase, shot all the way up from barely 1 all the way up to almost 12. We've come down, but if you notice, we're bumping up and down, up and down, up and down. So today we're at 7.25. Well, that was yesterday. We've probably gone up a little bit because of the data that we've gotten, but we are one of the highest in our region for deaths per million, and that is very worrying, right? One criteria I always talk about as well too is the rate of the increase of deaths. So if we look a few weeks ago and we look at how long it took for the number of total confirmed deaths to double, Trinidad was number 5 in the region, well, in the world, right? Right now we're right about number 10 or 11. There's a little bit of an outbreak happening in Fiji, where they're doubling in 7 days. Uganda, which is bad for them because their vaccination rate is near nil. They're doubling in about 8 days. And some of the other countries where we're seeing high numbers are like Cambodia and Taiwan and Mongolia and Zambia and so on. But again, we are doing better than we were around June 21st when we were doubling in 30 days. And before this, actually, 2 weeks before this, the highest that we reached was actually second in the world. So there was a time when our death rate was increasing, doubling at the highest level of rapidity in the world in terms of total confirmed deaths. So we are doing better, but not as good as we want to be, right? We're not in as good a position as we want to be when it looks at the death rate. How we test as well too is important because our positivity rate right now is around 13%. We need to get that around 5% as an indicator that all the epidemics that we have are under control. So if we look here, the more red the color, the more that country is in an epidemic state. The more blue the color, the more that country is in a control state. And that has to do a lot with testing because we have to cast a big surveillance net into our environment to be able to pull out those cases, right? So I always say you have to be careful on what tests that you go for. If you're showing symptoms, you should come to the lab to be tested for RT-PCR or antigen test to be able to determine whether or not you presently have infection. If you suspect you've been infected in the past, but you're not sure, then the antibody test is a good test for you to determine if you have any levels of antibody which shows infection, right? That has occurred in the past. not necessarily present. So there are ways that we do this. Generally, the positivity rate looks at RT-PCR. And again, that's the most accurate of the testing. We talked about this last week and I guess the week before. So I'm not going to reiterate it here, but just to emphasize that the positive rate is important as well too. So we want to get our number around 5%. That's really what we're going to, that actually makes us be able to understand exactly how that virus is spreading in our community, in our country. How are we doing? Well, worldwide, we're at 3.29 billion vaccines, which is great in that 43 doses per 100,000 people, 100 people, sorry, roughly about 43% in terms of single doses. However, there's a big disparity between cases of people who've been vaccinated around the world. For example, the entire continent of Africa is very underserviced, whereas countries like Canada is in upwards of 69%. In terms of vaccination, right? So these are some of the countries in our region. Antigua Barbados has done pretty well at about just over 30% fully vaccinated. Trinidad is right around 5.1% here in this thing, and the United States is roughly about 50%. Bahrain also has done pretty well. Here we're looking at Trinidad and Tobago. We've administered at least 351,469 doses of COVID-19 so far. And this is basically how we've done that over time. So as you can see, it's kind of a slow, gradual increase. But you know, we're looking at increasing those rates as more and more vaccines come into the country, which has to be done. In terms of our total vaccination rate, we're at 15.84%. I included some of the old data here just to kind of show us in comparison, since we've been starting and doing this, what the data has looked like over time. And June 16th, June 30th, we were we were at 12%, then we started to go at about 15.2%, 26%, we're about 15.84. So right now we're in a slow go state because we have stopped a lot of the first doses, and we're actually just doing second doses now, waiting for the next shipments. So we're slowing down, but we did pretty well there for a while, trying to get up, if you notice the curve here, but we're still pretty low compared to the rest of the world. Jamaica also is done not very well in terms of vaccination, in terms of their numbers, quite low, less than 5%. And India, again, has been creeping up, 25%. Barbados, Brazil, Guyana done quite well, but again, they need more vaccinations. Brazil has been increasing very steadily because they have their local production of the Chinese Sinopharm and a couple of the others that are available. But if you look at the big numbers here, a lot of them are the developed countries, Canada, UK, US, Germany, France, Italy. But then you're also seeing Israel, Bahrain, Maldives in there. A lot of the smaller island nations like Seychelles and so on have been able to actually get vaccinations donated. And because of their small populations, they're pretty high. I mean, of course, that may be the case for Barbados as well. But they've been able to get away with getting pretty good vaccines into arms in terms of numbers, pretty good numbers. And again, Trinidad's kind of leveling off now. We need to see that going up a little bit more like this in terms of vaccination. In the share of the population, we right now, as of July the 7th, we're 9.3% fully vaccinated, so we're less than 10% compared to the rest of the world. But look at the states of the African continent. They're all less than almost, in some cases, 1%, 5%. So they're in a pretty bad state. And there's certain regions, of course, around the world where we're seeing that, of course, because of the disparity and inequality between the vaccination spread. Just wanted to put this up because I thought it was interesting. This is some data from Reuters that actually showed what happened during the lockdown in terms of workplaces and when it started in correlation to our outbreaks. If you notice, when we started, we had a little blip of cases really compared to what we have now. And we implemented closing immediately, as well as lockdown in terms of the country, banning arrivals from all regions in terms of borders. And then we continued closing of certain sectors up until mid-July of this year, where now we have recommended closings of some, and we have some that's opening back. But generally, we're still under banning in terms of travel until, I guess, July 17th. So this has been kind of visual to be able to give you an idea of what's happening in terms of the lockdown measures in relation to our number of cases over time. One thing I wanted to start off with our myth busting now is that the way that SARS-CoV-2 came to be. So I mentioned it a little bit in the beginning, but a lot of people say that there's no way that SARS-CoV-2 mutated naturally. And I'm here to tell you, yes, there is a way, right? So generally, if you look at all our zoonotic spread of viruses over time, so we have things like SARS, the original SARS that happened in 2002, 2003. That pandemic was caused by SARS that jumped from a bat into a human host, right? Ebola, which decimated a lot of countries in Africa and the continent a few years ago, again from a zoonotic virus that jumped species. Same thing with all the flu that have caused all the pandemics throughout time, starting with the Spanish flu, the Asian flu, the bird flu, the swine flu, the avian flu. All of them have been associated with an initial animal host that was able to actually allow that virus to mutate and actually be affected because of illegal trafficking and wildlife trafficking and habitat destruction and stuff, have that close relationship or contact with a human that allowed for that virus to now come in contact with that human, mutate until it's able to actually infect. And then, of course, we know what happens next, pandemic, epidemic, or whatever it is. In this case, it was a big pandemic. So this is basically the accepted way that the virus SARS-CoV-2, as far as we know, if we look at the sequence data, we can actually see very, very clearly where that jump took place, where it jumped from bat to human. The earliest virus samples were back in October 2020, though, so I didn't want to mention that. So a lot of the new virus sequences that came out in December 2020 from the Wuhan market related infections did not include some of the earlier viral strains that they actually were able to find as early as October 2020. So there's some stuff in there that may have mutated before the initial Wuhan strains came out afterwards. Next myth, the Delta Plus and the Delta variant are the most deadly of all COVID-19. Why are we so worried about these guys? Well, they're variants. Now, of course, these viruses are going to mutate as viruses do, just for existence purposes. They don't intend to cause disease and severe disease and death. They just do just as a matter of course. And there's a particular variant called the Delta and Delta Plus, which is now mutated, which is the Delta now mutated again with another protein. So the Delta has the L45-2R, which changes the spike protein. Now, when that spike protein changes, the things that we have to fight against it also changes. Why? Because a lot of our attacks come from being able to identify that spike protein. And if that spike protein is no longer consensus, so our mRNA vaccines are again against a particular sequence of the spike proteins, our monoclonal antibodies against a particular sequence in those spike proteins, our diagnostics, how we find it through RT-PCR, is against a particular sequence. If that sequence changes too much, we're no longer able to detect, we're no longer able to fight, we're no longer able to prevent. And that becomes the big three problems that we have. And we're seeing that with the Delta, not as great as we would fear, but it's happening. And we're also seeing it with the Delta Plus that also has another mutation called K417N, which also changes the spike protein, right? So basically we have a spike protein that's looking very different from the original spike protein that most of our artillery, i.e. our detection, our therapeutics and our vaccines are designed against. So it is also more transmissible, almost as 80% more transmissible. It's taken over the UK. It's about 98% right now in terms of COVID cases in the UK. It's slowly taken over the US and it's present in about 97 countries right now. The monoclonal antibodies still work against it, but we are saying that it might change over time. We have to keep looking at it. Children seem to be at greater risk in that more children are becoming infected with the Delta Plus as they did with the Gamma, which was the previous variant, again, that had these mutations in the spike proteins, but we don't have any indication it's causing more severe disease. It seems to be more transmissible and able to infect children with more efficacy, but it's not, doesn't seem to be killing them or causing very severe disease, right, which is great. But we're still worried because of the lack of vaccination around the world, right? That's really a big problem. The more unvaccinated people exist, the more these variants are going to infect them. They can now even mutate further to become even more have more evasion tactics against the neutralization capacity of our antibodies and our detection and our ability to be able to prevent it. And that is why we are very worried. Another myth that we like to bust is that vaccines cause deaths, right? I would like to just declare this conclusively right now that all the COVID deaths that have been occurring in the US in terms of people who've been vaccinated versus people who are unvaccinated have been occurring in the unvaccinated. Now, people who are vaccinated are getting sick, but they're not dying, right? So 0.8% of deaths in May were among fully vaccinated individuals. So that is basically very, very low compared to the number of deaths that we're seeing, right? So that's still good news. Another myth that most vaccinated people die from COVID-19. Vaccinated people might die, as I just mentioned, 0.08% of them in the US. This particular case here, they're talking about 70 people that had at least one dose, and 44 of the people who had not been vaccinated, and 50 of the deaths were people who had received both doses. But these people were older, they had comorbidities, and they were probably more susceptible to disease anyway, right? So that's one of the reasons why we're prioritizing the elderly and the vulnerable, because we're giving them a fighting chance with vaccines. We're not saying that there's no way that you'll die from COVID-19 if you're vaccinated, because there are always breakthrough cases. There are always people who have really, really severe comorbidities, people who are older, who might still die, but we're giving you a fighting chance. That's really what we're doing, right? In particular, in the UK with the Delta, 61% of the COVID-19 deaths were people who have received only one vaccine dose. So that means that they weren't fully protected, right? No vaccine is 100% effective. So many vulnerable people can be vaccinated and still get virus and can still possibly die from it. We're not saying that you will not ever 100% be survive, but against the original variants, we're seeing really, really high prevention against severe disease and death. And against these variants that are really bad guys, we're seeing upwards of 62, 72% protection, right? Which is still something better than nothing. The vaccine itself, another myth. I've heard this over and over again. The vaccine is killing more people than COVID-19. No, right? The death rate among COVID-19 vaccination people is not higher. It's much, much lower. In fact, people who are 65 or older are 94% less likely to be hospitalized with COVID-19 if they're fully vaccinated versus people who are not. People who are 64% less likely if they've only received one dose. Even one dose will be protective. And this is real world data looking at Pfizer and Moderna in particular in the US. And we have more information from this in terms of the UK and so on with AstraZeneca and other parts of the world with Sinopharm. There are only tens of individuals who are likely to die from COVID-19 vaccine adverse effects, and none of them have died from COVID-19 infection because of the vaccine, right? Let me just put that straight out there. In terms of the, right, so here I just want to say conclusively that vaccines are very safe. They've been subjected to many phase 3 trials all around the world. Some of these vaccines are available in over 178 countries with the Oxford AstraZeneca, Pfizer and Moderna and so on are, in the 70s and 80s in terms of the numbers of countries. Sinopharm is 78, and they're generally very safe. There's a lot of anti-vaccine literature out there, but you have to be very discerning in what you read. You must make sure you read a published peer-reviewed journal article. Our group was just forced to retract a publication that was done in a journal called Vaccines because of questionable conclusions that they drew, not based on the data, but based on their personal view. And that's one of the things that we have to look at. If you are looking at a well-reviewed publication that actually can give you information, or organization like the WHO or one of the FDAs in one of the countries that you're looking at, the regulatory bodies, those are the kinds of people that's going to give you real information. You look at NCBI, you look at Google Scholar and try to get some of that information from published peer-reviewed literature. And that's where you get this from. That's where you get facts from. You're not going to get facts from a YouTube, Instagram influencer, right? It's not going to happen. So vaccines generally are very safe. You're going to get the side effects, yes, because vaccines are designed to irritate your body to get an immune response. But the adverse effects generally are temporary, except for very rare cases where they have serious adverse effects. And those are not side effects. Those are going to be serious adverse effects, like the Pfizer myocarditis, the blood clotting, which I'll come to just now, with certain of the vaccines, those things are rare, and a ratio, I think it's 1 in a million, 4 in a million, 5 in a million. That's the kind of numbers we're looking at, right? So the risk is much, much lower of dying from a vaccine than dying from COVID-19. Just want to bust that myth right there, right? You have a much, much bigger chance of dying from COVID-19 than any vaccine. Vaccines do not work. So that's generally some things that people say specifically, and they might throw in a group. So some people might say, vaccines do not work on obese people. Well, we have a lot of data that shows that it does, right? For example, this study here, the Obesity Society did published some work with a group of scientists that shows that yes, all the EU A vaccines that are available in the US are effective with individuals who are obese, and the efficacy of the vaccine is not reduced based on that particular comorbidity, right? And that is similar for all the comorbidities that I've looked at in most of the research, and that's cardiovascular disease, immunocompromised patients, HIV positive patients. All of those people will be protected against these COVID-19 through vaccination. Now, if you're immunocompromised, obviously your protection might be lower, but you'll still be protected, right? One thing to be concerned about, there's whether or not this is a myth or not, that COVID-19 vaccines can affect test results. In the case of swollen glands and those kinds of things, if you're going for mammograms or CT scans and those kinds of things, yes, they can. Because again, you're raising an immune response. When you raise the immune response, you get things like swollen glands, you get things like basically your body's fighting an infection because we're pretending that it's infected in order for you to be able to get immunity and antibodies, right? Through a unnatural infection, so to speak, that we are controlling. So you have to be really careful with this. You have to wait up to 10 days for these kinds of things to pass. If you're due for breast screening or any kind of CT scan or anything like that, be careful. Mention that you've had the vaccination so that they know, and wait at least 6 weeks to do a mammogram in particular, and probably about 4 weeks to do something like a CT scan in certain areas because of this, right? So this particular myth is actually true. COVID-19 vaccines can affect test results. What's going on with my slideshow? It's going really slow. But anyway, another myth. Everyone in the entire world needs to get vaccinated. No, that is not true. There are certain people that should not take the vaccine. If you have a temporary fever, you should not take the vaccine. If you are at risk for anything that's an allergic response, you should not take the vaccine. People who have clotting disorders and those kinds of things need to be evaluated before they take any vaccine. People who have allergic responses to vaccines and the components of the vaccines shouldn't take the vaccines. And depending on your allergic response, if you have to walk around with an EpiPen, if your throat closes up, that kind of stuff, you need to seek doctor's advice before you're vaccinated, right? The vaccines that are WHO approved have all been shown to be safe and effective with people who have increased risk of severe disease. That's people with comorbidities like hypertension, diabetes, asthma, kidney disease, chronic infections, people who have been immunocompromised, HIV positive people, pregnant or breastfeeding people, those individuals, and of course, healthcare workers and those kinds of things are also deemed to be in that group that should get vaccinated first, right? If you have been infected with COVID-19, you can defer your vaccination. But you're recommended to get that vaccination at least minimum 2 weeks post infection. If you are asymptomatic, you can do a COVID antibody test to determine your COVID status, to be able to determine whether or not you could take the vaccine or wait again 2 to 4 weeks or however long it is you want. Lactating women and pregnant women were not included in the initial clinical trials, but right now we have over 1.5 million people who've taken it, either pregnant or breastfeeding, and none of them are showing increased risk of adverse side effects or adverse risk effects, I should say. And actually they're giving immunity to their offspring either through the breast milk or crossing the placenta. So it's actually giving those infants who are now able to have a certain level of antibody response against the vaccine. So it's actually seen to be good and recommended in certain areas, right? In certain regions, they're recommending it, especially if you have a high COVID risk of infection. Right, there's another myth. I can get COVID-19 after my first dose. If that's true, yes, I would say it's possible. One vaccine reduces your chance of death and severe disease. However, as I mentioned before, no vaccine is 100% effective. So breakthrough cases can occur. There was one research article that I showed, 5,732 breakthrough cases from 50 million doses of vaccines. So again, very low, risk, roughly 0.01, 0.08 around there. But there is a risk. Efficacy is generally between 50 to 70%, but there are cases around the world that people with one dose of vaccine getting severe disease, but generally they do not die, right? So vaccine will still reduce your chance of death and severe disease, but it is not, it's not fail safe, right? Can you get COVID-19 from the vaccine? No. You will get side effects, and your side effects, of course, are a sign that the vaccine is working in your body, immune system is responding. You might get a fever, you might get aches and pains, because your antibodies are being produced, your T cells are coming out and fighting and telling the rest of the body that, listen, we have an infection here. So your body is going to kind of look like if it's infected, even though truthfully it's not. So that will usually, dissipate within your first 24 to 48 hours, generally, usually 3 days max. But you do not have COVID-19, right? There's no way that these vaccines, none of these vaccines can give you that virus, right? What we use are mRNA, little pieces of sequences, or we use inactivated killed virus, or we use protein subunit viruses, little parts of the virus. So you have no ability for that vaccine to infect you because it is no longer able to replicate in your body or through the vaccine or cause infection, right? But after vaccination, it usually takes a minimum of 2 weeks. So it's possible that some people can be infected with SARS-CoV-2 just before vaccination or just after their first shot and still get sick from it, because the vaccine, of course, has not had any time to provide protection, because you're really only fully immune 2 weeks after your second dose, right? So you can still die, you can still get severe disease, and you can still transmit COVID-19 if you've only gotten one dose or shortly after or shortly before you've gotten one dose, right? So that's an important delineation. You are really only protected fully as much as we've been able to protect you from vaccination 2 weeks after your second dose, right? And of course, it depends on what variant you're exposed to as well. So the COVID-19 vaccine is non-infectious, does not contain a virus, and cannot give you COVID-19. 100% myth busting right there, right? In terms of the timing of the second dose, can you space out the doses? Yes. Extra time can help. We know that 1 month was used initially, but we know now they've waited as much as 3 to 4 months in some cases, depending on the vaccine, depending on the location, depending on whether or not they had vaccine to give you for a second dose. So it's not a doom and gloom. Don't panic if your second dose is not there when you need it, or when it's written on your card or whatever. These things can be spaced out, right? So that's one of the things. It's okay to space out your second dose once you get it within 4 to 6 months of your first dose, right? And in some cases, we're giving boosters now and recommending boosters 6 to 12 months after your second dose, depending on the country, right? So that's also important. Are there more side effects with the AstraZeneca vaccine? Not generally. There's no evidence per se to support that. You generally have the pain, itching, pain, and that kind of, not the ability to move your arm, those kinds of things, feeling tired, fatigued, chills, fever, feeling feverish, chills. People experience a lot with the AstraZeneca, headache, nausea, and most importantly, muscle ache and joint pain. That's one of the things that's most common with both the AstraZeneca, the Sinopharm, and the Pfizer and Moderna as well. So basically, a lot of these are very similar to what we see in the other mRNA vaccines, including Johnson & Johnson and even the Sinopharm. So no, generally, you don't get more side effects with the AstraZeneca. Another myth, transmission of COVID-19 is greater after the vaccine. So there was a preprint study by Public Health, which found that 3 weeks after a single dose of either Pfizer and AstraZeneca, household transmission of the virus was reduced up to almost 50%, which is great. There's some research that's come out to actually show that this is actually even larger, as much as 60 to 70%, even after a single dose. So it suggests that even after the first dose, you can get significant reduction in the spread of the virus, right? So after even a single vaccine, you can get that. But you can still, of course, spread it. But that individual who is been vaccinated cannot spread it with as much efficiency as if they were unvaccinated. So even one dose of COVID-19 vaccine reduces and gives a good protection against transmission, again, which is good news. The vaccine, another myth, vaccine does not protect against new variants. Lots of data showing that it's protective against the Alpha and Delta out of the UK. Brazil and South Africa, again, the Sinopharm, Sinovac shown to be very effective in Brazil against the Gamma Oxford AstraZeneca as well against the Beta and the Gamma, and of course, and the Delta in terms of Brazil and India, and of course, the UK. So we're seeing quite a bit of data that's coming out, because what is happening is that these individuals are actually documenting what's happening when these people are being vaccinated in the areas that are having these peaks of different variants. So if they are peaking Delta, if they're peaking Gamma, if they're peaking Beta, and they're actually able to test it. The early vaccines that came out, the Pfizer and the Moderna, didn't have that luxury, because of course they came out just in time to look at the original strains and the wild type of the more related to the Wuhan Chinese strains. And these guys came out when a lot of these variants were in circulation, which was good in that we're able to see that they were effective or not, right? So Pfizer is showing 87.9% efficacy against Delta, and AstraZeneca is showing 59.8% in this particular study in the UK, where some of the ones that haven't come out from WHO yet, the Novavax, is showing very effective data against the Alpha variant, as well as against the Beta and some of the others, and I guess the Sinopharm and the Sinovac, as I mentioned, good protection against the Gamma in Brazil. Another myth that I've heard over and over, and I'd like to address, that vaccines can cause infertility. There's no published evidence that there's any kind of cross-reactivity between the viral S protein and the placental protein. That's what some of the anti-vaxxers have been putting forward. And it's not plausible that one little small 3-peptide part of the viral protein is going to produce some sort of cross-activity. That's just not how antibodies work, right? Women have contracted COVID-19, and there hasn't been any reports to date of infertility, which would have been the case if it was true. And any of the S protein produced by the mRNA vaccines is the exact same as the S protein in the SARS-CoV-2 virus. But if the hypothesis was true, then we would be seeing this infertility in natural infection at much, much higher amounts, right? So if there was any weird cross-reactivity between these, then there's even more reason to actually get a vaccine to prevent infection, because you'd be seeing that with the COVID-19 infection at much, much higher rates. So there's no reasonable basis to believe that any vaccines would cause any fertility issues in women at all, as of now to date. However, COVID-19 infections may, right? What about erectile dysfunction? That's another question that we get quite often. There hasn't been, and no vaccine manufacturer research has afforded any information from any of the phase 3 trials to show that this can occur. However, COVID-19 infection causes almost a 63% increase post-COVID-19 infection of erectile dysfunction. So that's something to be concerned with. And in terms of sperm count and male fertility, the COVID-19 vaccine hasn't shown that to be negative at all. But the COVID-19 infection has shown lower sperm count in men who've gotten sick with COVID-19, but we don't know, again, how long-term this is, because a lot of this data, of course, is, ad lib as it comes out, right? And none were noticed after the vaccination, right? So in fact, vaccination can protect you against erectile dysfunction because it can prevent COVID-19 infection. So I urge individuals who are concerned about erectile dysfunction to actually be vaccinated as soon as you can to prevent that from occurring with COVID-19 natural infection. There's another myth that you could just take one shot of COVID-19 and just walk away. Well, I mentioned that before. You get a certain amount of immunity from one, however, you are still susceptible to infection, so this is not a good idea, right? You need to be able to get that second dose. It's almost like you just go to primary school and you just learn how to read. With your first dose, your second dose is going to take you to university, post high school and stuff, right? So that's important to get your second dose. Do vaccinated people shed COVID-19? No, they can only shed COVID-19 if they're infected with the COVID-19 virus, completely independent of the vaccine. If I'm vaccinated with a particular vaccine against measles or mumps or rubella, I'm not going to shed measles, mumps, or rubella. If I'm vaccinated against rabies, if I'm vaccinated against hepatitis B, if I'm vaccinated against SARS-CoV-2 virus, I will not shed the virus, right? That immunity is mine and mine alone. I would not shed antibodies either, because they're only available to me in my immune system, right? So this is absolutely false. Vaccinated people cannot shed COVID-19 from the vaccine. However, they can if they were infected with the COVID-19 virus post-vaccination with one vaccine or pre-vaccination, and they didn't get a full immunity prior to being infected. So in those cases, yes, right? Can vaccines disrupt your period? This is another thing. No, there's no evidence that vaccines can disrupt your menstrual period. And there's no possibility that a vaccinated person can affect your period by shedding, because I just mentioned there's nothing to shed, right? None of the vaccine ingredients can ever leave my body. If I drink milk, the milk is not leaving my body except, of course, via digestion and those kinds of things. And there's no way that it can shed from my skin or shed from my nose or mouth. Similarly, same thing with the vaccine. It does not, no. Stop that particular rumor right in its tracks. There's no way. In terms of mixing vaccines, does your second dose have to be the same as your first? That was the initial recommendations. However, some vaccinologists and some studies, clinical studies, have shown that getting a different type of COVID-19 for your second dose can actually stimulate immune cells to focus on the right target. And they're actually recommending mixing doses in Canada and the European Union, in part because they did some testing with Pfizer followed by AstraZeneca, and AstraZeneca followed by Pfizer. And some countries have done Sinopharm followed by Pfizer, and actually showing very good response in that you're getting longer and stronger immunity. So mixing vaccines seems to be okay, but you would have to be, of course, following the regulation of your country, of your area. In particular, Trinidad and Tobago, we're not mixing vaccines yet. We are told by the regulators and the Ministry of Health that you have to follow up with your second same dose of your same manufacturing company of your vaccine, right? But this might change in the future. I mentioned the blood clots briefly. All vaccines cause blood clots. People are very, very scared of these blood clots, which is really ironic because although the AstraZeneca, Johnson & Johnson, Moderna, and Pfizer all have a higher risk of blood clots than if you were just walking around the streets. And by higher, I mean 4 in a million for AstraZeneca, 4 in a million for Pfizer, 5 in a million for Moderna, and 1 in a million for Johnson & Johnson. Let's look at the risk if you're on birth control. 500 to 1,200 in a million. Smoking, 1,763 per million. And what about natural COVID-19 infection? Almost 16.5% increase. So the risk of clotting is very low with the mRNA vaccines, and much, much lower if you're looking at the other vaccines like the inactivated vaccines, the peptide vaccines, and those guys. They still have a risk, but these are much, much lower. You have a much greater risk of getting a blood clot and dying from a blood clot through COVID-19 infection. Okay. Children and pregnant women cannot take the vaccine at all. Well, the initial trials were done in 18 to 64, then 65 and over, but we've since shown positive protection with mRNA vaccines, 16 and over. That's Moderna and Pfizer. And Pfizer was also approved for 12 to 15, sorry. And they've applied for the EUA for the under 12s. We're waiting to see whether or not they get through or whether or not they're going to be forced to go through the normal FDA. This is in the US. The FDA kind of as a model for the other countries. I think everybody's waiting to see how they approach it. Eventually, every demographic has to be vaccinated, and that's the route we're going to go. But for right now, 12 and above are recommended. Pregnant and breastfeeding women are recommended if they're in areas where the COVID-19 risk is great to them, right? They're over, I think, 1.5 or 1 million people, as I mentioned, who have been pregnant or breastfeeding that have taken the vaccine safely and have had no issues. COVID-19, oh, I mentioned this one already. Right, I wanted to mention this one. This is a fun one. People think if they rinse their noses with saline, the virus will disappear. Evidence has indicated that rinsing your nose with saline can help you recover faster from the common cold, but unfortunately with infectious respiratory diseases like COVID-19, where it's actually entered into your lungs, this is not very helpful because it kind of passes through too quickly to really do any good. So good idea to do it just as a matter of sanitary reasons for preventing things like, you know, the ones that actually stick around here, but not very effective against the COVID-19 SARS-CoV-2 virus. Preventative drugs. Right now, the WHO has not been recommending drugs to prevent, like prophylactic prevention of the disease. There are things like ivermectin and these kinds of ones that people have been using. Most of the drugs that we're using for treatment are like the dexamethasone, the remdesivir, the antivirals, and of course the tocilizumab and the other types of antibodies, monoclonal antibodies, and the IL-6 antibodies that other countries are using. That's the kind of stuff that they're using to treat severe disease, but generally nothing prophylactic yet. Virus can be transmitted on objects. Is this a myth? No, it can last on the surfaces for many hours. Can you get it if people are importing products from other countries and so on that have high rates of infection? The environment, transportation, and varying temperatures might kill it during shipment, so the virus may not remain alive. But if you feel as if it's contaminated, please disinfect and wash your hands after touching it, right? Generally, that's good standard to do, because virus can be transmitted on objects to a certain extent. So that one is particularly true, or can be true, I should say. Virus can be transmitted by mosquitoes. No, right now they're not showing that any respiratory disease can be transmitted by mosquitoes, including SARS-CoV-2, because again, you need to get the engagement of the mucous membranes, like the coughing, sneezing through the mouth and nose, contact with the patient's saliva, that kind of stuff, right? So right now the mosquitoes are safe, at least from us, for SARS-CoV-2. Drinking alcohol will kill SARS-CoV-2. A lot of guys ask me this. Puncheon, beer, liquor, wine does not help prevent coronavirus, right? Sad to say, all you will do is get yourself drunk and probably compromise your immune system even more than it needs to be compromised, and it's not a good idea, especially post-vaccination. Not a good idea to drink 24 to 48 hours post-vaccination, again, because you want your body to concentrate on making antibodies and reacting to the vaccine. You don't want your body wasting time trying to, get water from your kidney to rehydrate your brain and all the things that happen when it is you have a hangover, right? So don't drink alcohol at least 24 to 48 hours after you get your vaccination. And no, it does not kill SARS-CoV-2. Clothes cannot transmit SARS-CoV-2 virus. True or false? Yes, clothes can, because technically it can be alive on clothes for a short period of time. Now, if you bathe every day, if you wash your clothes using detergents or soap and temperature, hot water, add bleach, those kinds of things, dry it in the sun, or in a high temperature dryer, you should be fine. So this one is kind of true. The clothes can transmit SARS-CoV-2, especially if you've been around infected people. If you are not wearing PPE and you're a health worker, yes, you can transmit SARS-CoV-2 to others via your clothing. This is a big one. This was a big political issue in Trinidad with the hot climate transmitting less virus. While it can be transmitted in any kind of climate, you have to practice personal hygiene. You have to wash your hands, you have to cover your mouth, you have to sneeze, and when you sneeze or cough, when you talk, and wear masks. Regardless of how hot it is, we've seen it. We've seen surges in summer, we've seen surges in winter, everything in between. So hot climates do not transmit less virus. So this one is actually false. Digital thermometers, we've all been subjected to it. Everybody walks into a store, walks into the supermarket, whatever it is, the bank, and they're using these digital thermometers. Are they effective? No, they're not, because it could take the virus 1 to 14 days to incubate and cause symptoms like a fever. So it cannot be used to identify asymptomatic patients. If you are in full-blown fever, yes, it can identify you. It doesn't necessarily mean that you're COVID-19 positive. However, you can have a fever for another reason. So while this is kind of used, it can't really give you any information on COVID-19, right? So this one is not true. There's no need to vaccinate if you have natural immunity. We don't know how long natural immunity lasts. Coronaviruses are notorious, like the cold virus, for having very, very short space of time for immunity. That's why we keep getting the cold over and over again, sometimes 2 and 3 times in the same season, because the immunity does not last. We are lucky in that we have seen so far to date our vaccination giving us lasting immunity, lasting upwards of 15 months, which is the time we've been vaccinating for. However, the COVID-19 natural infections not showing us that level of immunity yet. So we are recommending, even if you've been infected with COVID-19, that you get your vaccination for 2 reasons. Number one, it could clear up some of your long haul COVID symptoms that a lot of these individuals are having post-COVID-19 infection. They're getting a lot of aches and pains and a lot of issues that are very strange to a lot of immunologists and people who are trying to help them, and infectious disease specialists. And they're actually alleviating those symptoms through vaccination, because it looks like the vaccination is giving them a boost, reducing inflammation, probably getting rid of some latent virus that may be sticking around there. Lots of different reasons, but it's really recommended, even if you've been infected with COVID-19, you go for the long-term immunity by getting your vaccination. Vaccines prevent infection from SARS-CoV-2. True or false? No. You can still get infected with SARS-CoV-2 if you've been vaccinated, even if you've been doubly vaccinated. However, you have reduced your chance of having severe disease and death by, almost 80% in some cases, depending on your demographic. If you're immunocompromised, if you are older, if you have comorbidities, right? They've all been licensed. All of the WHO vaccines have been licensed right now, and they have known to be almost 100% effective against death and severe disease of the known variants that they were tested against. As I said, a lot of vaccines are being remade now to be more effective against different variants. Sometimes we're having ones that have actually multiple variants in them that are able to actually prevent disease, and that's great. But right now, the pool of vaccines that we have available to us prevent against severe disease and infection and death, but do not prevent infection. So you can still shed virus to others if you've been vaccinated, if you get COVID-19 infection, right? You probably won't get severe disease and death. You might still be infected. You may still have symptoms, but that ability to shed is still there. So you must still wear a mask and all of those kinds of things, right? I have to emphasize that. If your immunity can weaken over time as well too, if you're vaccinated, that will help you. And then of course, if you wear your mask as well, that's going to help. The SARS-CoV-2 virus typically lives here, enters here, comes out here. So you need to block this, right? It's possible as well to carry around, even though the virus is not replicating generally in people who are vaccinated with 2 vaccines, 2 weeks post-vaccination, you are still, in some people who have comorbidities, some people who are immunosuppressed, you can still get those breakthrough infections where it's replicating. Generally, it doesn't replicate, but it's still enough for you to be able to infect somebody else. You may still be able to carry enough viral load that's strong enough to be able to cough and sneeze on your child who's not vaccinated, because remember, 100% of children right now in the world of younger than 12 are not vaccinated. You can still give it to them. You can give it to your elder individuals at home who are not vaccinated, people who cannot take the vaccine. You can be a transmitter. So you need to be very, very aware. I wanted to address the stuff about the lotteries, just because some people are saying, well, you know, people doing lotteries in the States and in all kinds of things, they want to bribe us. We're not falling for that. It's not about that, you know. At the end of the day, people have to get rid of a lot of the vaccine hesitancy in order to be able to achieve herd immunity in their community. So what we're trying to do, and what a lot of countries are trying to do, is to have what we call mini herd immunity. So they're trying to, if you notice in Trinidad, they're opening it up for certain areas. So like the construction workers got certain amount of vaccines. The energy sector got vaccines. The Ministry of Education teachers got vaccines and workers. Those people who are around each other to kind of generate this idea of having mini herd immunities. And that's what they're doing in communities all over the world. So they actually have what they call regret lotteries, which I find is so cool. And they notify you if you would have won had you been vaccinated. So that's really, you know, that's really interesting. So not only is it there are lotteries for vaccination where they enter your name if you've been vaccinated and you could win $1 million, and some people are being encouraged to be vaccinated like that. They also have these regret lotteries that that is a kind of a strategy to address vaccine hesitancy, and it's actually been working, right? Because a lot of people, you know, almost 20% of people or so are just hesitant, and for no real reason. They haven't approached education kind of way to be able to figure out, well, why am I hesitant? Why should I not do this? What should I do to change my views? You know, the world really needs to be able to identify that. So this particular individual here got infected and he was actually testifying in front of Congress, that is actually pleading with Americans to be vaccinated because he suffered so much from his experience, and he's saying that he's been given a second chance in life, and he wants to become a vaccine advocate now to teach people what happens if you are hesitant, and what happens if you're part of a vulnerable community who's at risk. And there's certain people who are doing this 4-point plan, which is very important to identify communities at risk, kind of what we did here in Trinidad, like the energy sector, the people who are, of course, healthcare workers, the frontline workers, the supermarkets, teachers, those kinds of things, and be able to say, okay, let's work with you and figure out why you are hesitant. How can I help you understand what is happening here? And engage them to kind of decrease that. And then, of course, monitor whatever actions need to take place. So this kind of has to happen over and over and over again to be able to spread those mini herds into getting a wide enough herd to be able to cover herd immunity and have us protected. You can't sit around and think that as an unvaccinated person, you're not going to affect others. That is a total myth, because the relatively few cases of infectious disease that our country currently has can spread to become tens and hundreds. We've seen that in Trinidad, what happened with the surge. Without protection of vaccines, less protected we are, the more at risk we are for these surges to be, and these little mini epidemics to be out of control. So There's a small amount of people who cannot be vaccinated, yes, because of severe allergies, because of their particular personal conditions, and those people are susceptible to disease, and we have to do what we have to do to be able to protect them. So as unvaccinated individuals, you're going to put those allergic people, older people, immunocompromised people, and of course children, to 100% of people under 12 at risk. So that's the way we have to think. It is irresponsible for a driver to ignore all traffic regulations on the presumption that all the other drivers are going to drive for them. Although we have to kind of do that in Trinidad. But anyway, the same way we shouldn't try to rely on people around us to stop the spread of disease. We have to do what we can to be able to do it. Can we eradicate it like we did smallpox? Yes, we can. Diseases did not just disappear because of better hygiene and sanitation. They disappeared because of vaccination. If we look at the rates of increase of vaccination and the survival rates, they're almost directly 100% correlated. Over time, we've been able to eradicate smallpox 40 years ago. We've decreased measles, mumps, rubella. Polio is almost eliminated. Since all of these vaccines have appeared over time, we're actually seeing those decreases in these vaccine-treatable diseases. So yes, we can do it if we work together as communities within the entire world community to be able to reach that herd immunity. Finally, the biggest myth of all, COVID-19 vaccines do not work. I just let the slide speak for itself over and over and over again. The trends in COVID-19 deaths against fully vaccinated people in the United States, this is January the 20th, 2021, 3.4 million people were vaccinated. Ending on the 7th of June, 140.4 million people vaccinated. And if you look at the direct negative correlation, as soon as these vaccines started to get in arms, the deaths started dropping. Right now it's at 224, actually, daily deaths on the 7-day rolling average. So this is 100% proof that COVID-19 vaccinations works. So yes, it does. And how do we end it? Again, I showed you this at the beginning. Yes, we have to limit the host so we don't get those zoonotic jumps. We have to reduce trafficking and get rid of all that illegal wildlife trading and all of that. Yes, because the more we expose, the more we encroach in these environments, the more we have climate change because of our activities, we're going to cause these things to happen onto us. We have to be able to wear the mask, portals of entries have to be blocked. We have to be able to sanitize, maintain distance, isolate to stop the mode of transmission person to person. If you're in an office, open a window, put on a fan, those kinds of things. Do not be able to have that direct transmission readily there. And of course, again, wear masks to the portal of entry to the nose and mouth for it to exit. But if we vaccinate, we get rid of the susceptible hosts. If we get rid of the susceptible hosts, we're going to have herd immunity, and this ends. That's how we end it, through herd immunity. So we want to be able to eliminate this virus and this pandemic. We want to be able to be down here, these yellow guys, where most of the population gets immunized to contain the spread of disease. So these red guys who are infected, we're not going to have a scene like this up here, where everybody is going to get infected because we're all immune compromised, or immune naive. We want to be able to get as many people vaccinated as we can to protect those of us who can't be vaccinated, because there's always going to be a certain amount of the population. So do not bring that vaccine home to your children. You have to sanitize, you have to wear your mask, you have to be able to do all of your stuff similarly how we did before your vaccine, after your vaccine, socially distance until we get the stuff under control. We have 91% of our population in Trinidad still susceptible for this virus, who can act as virus incubators, incubating this virus beyond the deltas, beyond the gammas that we see in other countries, causing big devastation due to severe disease and death. And we have to be responsible and take this vaccination when it's offered to us as quickly as it's offered to us. We need to demand vaccination. We need to get it. It's our right to be vaccinated, and as well as to be educated. So I hope this has been useful, and we will go on to questions now.
All right. Thank you so much, Dr. Chan, for that very detailed and clinical presentation. I thought if we were not, if we were fearful of the vaccine and what it is, I think you would have allayed some of those fears. Even myself, I had some questions which you during your presentation you did respond to. But before we end, we just have a few minutes before we end the session, and we would like to just indicate that our viewers, they're free to send in their questions to us at this time while we have you while we have you on the spotlight, Dr. Ramlachan, in explaining to us and treating with some of the myths and as our topic indicates, hype or hope, investigating the COVID-19 vaccines. Dr. Ramlachan, I have a question here which I've heard from a lot of people, and it, I suppose, can fall into one of those myth categories. You listed quite a lot there. There's a view that how safe should the COVID-19 vaccines be when there would have appeared to have been what some people describe as a hurried approach in terms of getting the vaccines under what the WHO has been called, what a lot of people have been calling emergency regulations. We have known that for when we talk about vaccinations and vaccines usually take years in terms of studies and research and trials and so. But here we have in 2020, spanning 2020 to 2021, you have almost 4, 5, 6 vaccines that have been rolled out to the population, and I think that that particular area has been also a concern to a lot of people, and has also contributed to the vaccine hesitancy that we've seen over the few months, and over from 2020 to 2021. How do you respond to that?
We actually did, I believe it was our 4th session on vaccines, how they were developed. And then we did a session 2 weeks ago on vaccine safety. And we kind of went through that in great detail, part of the same Hyper Hope series, in terms of teaching people exactly, number one, how these vaccines came about, and then exactly how they were produced. Again, there are different types of vaccines. You have your mRNA vaccines, you have your mRNA vector vaccines, you have your whole inactivated vaccines, and then we have more and more that are coming out that are not WHO approved yet, that are like your single peptide, your protein subunits, all kinds of different versions of that, even some DNA vaccines and so on, that are coming out, and some that can be administered via your nose, some that can be administered via the patch, like a nicotine patch, all kinds of different things that are happening, and then some that are pan-viral vaccines that actually have the different variants in them. And the safety and efficacy are evaluated in different ways, basically phase 1, phase 2, phase 3 trials. And we went through that kind of in great detail, so I don't want to repeat myself, but generally, I usually have to contend with that question a lot. And usually my answer is that no scientist in their right mind wants to produce a vaccine that's going to kill people. Right? That is flat out the truth. Nobody wants to be the one that kills millions of people because they invented or they produced an effective vaccine. Either a manufacturer, of course, at that scale, and no individual scientist. So people worked very, very hard. And what occurred is that a lot of this information was there before. So, for example, I mentioned the Ebola zoonotic pandemic that we had a few years back in 2016, 2014. To 2016, and again in 2018 in Africa, and they actually used mRNA vaccines. So they used the technology very recently. So that technology has been around for about 15 to 20 years in particular. I mentioned the old school inactivated vaccines like the Sinopharm and Sinovac. I mean, we've been using that since the smallpox days, right? Technically, we've been killing virus since 200 years ago, since Salk, right? So this is not new, right? This is not new to anybody. So the idea that this is something that happened overnight is false. And again, the efficacy data, it's totally a myth. And I mean, we busted that. I mentioned it a little bit in one of the slides, but vaccines are safe. But they are generally very effective for what we have designed them for, which is severe disease and death. That's basically it. Because initially, when this pandemic occurred, that's what we were seeing. We were basically seeing severe disease and death, because at that point in time, we didn't even know about asymptomatic people. That came on later when we started testing and doing more surveillance, and we just weren't testing people who showed symptoms. We were testing everybody. And then we started to realize, well, look, we're actually seeing 75% people walking around and they have no symptoms. So that information was what was fed to these vaccine developers. So everybody was just in it for saving lives, decreasing severe disease and death. And that's what we're seeing. Now, luckily, we've lucked out with the variants. So most of the variants that we have are the most variants of concern. We have no variants of high significance yet. The high significance ones are the ones that evade immunity from vaccines completely, evade detection, evade everything, right? And we're not seeing that kind of stuff happening yet. We've been able to identify COVID-19 viruses in individuals who've been infected and showing symptoms and had severe disease and death, and all using the same tools, treated them with the monoclonal antibodies and therapeutics, and most importantly, vaccinate people. And we've been seeing, again, efficacious vaccines against the Delta and Gamma, which have been the worst of the worst right now, right? Again, they're breaking through. We're actually seeing people who are vaccinated who are seeing having symptoms, and we're seeing them in hospitals and so on, but they're not dying at those levels that would happen in the early days. And that's because of the vaccinologists. That's because of the immunologists that worked day and night and killed themselves to be able to produce this. And one thing that people have to remember, and I don't think they associate this enough, lots and lots of money was thrown at these vaccines.
Yes.
And scientists will always tell you, if you give me enough money, I could give you what you want, right? And that has always been that. I mean, as a scientist, I'll tell you that has always been the factor that blocks you the most is the cash. And they literally had unlimited cash in some cases, because not only were governments giving them money, private organizations were giving money, all kinds of people were just pumping money into the Pfizer, the Moderna, the AstraZeneca, Oxford AstraZeneca, the Johnson & Johnson. These people got a lot of money in the earlys very, very quickly. And they were able to do their job very fast.
Okay. Dr. Ramnath, I think we got a question. We have a question coming in from one of our viewers, and the person, Kiran Kirby, I hope I have that name correctly. The person says, regarding the reports of Sinopharm causing individuals to contract COVID-19, is this actual fact, or is there some sort of mid-vaccine exposure to the virus that causes them to get sick?
Well, there are two reasons. I mean, some people are getting COVID-19 before they even vaccinated with one vaccine, right? So whether it's Sinopharm or AstraZeneca, they would have shown symptoms anyway, right? Also, too, after your first vaccine, you only get a certain amount of protection. So you're still susceptible. So technically, you still have to wear a mask. You still have to do all your stuff, because you can still contract and die from COVID-19. If you get your second vaccine, again, you can still contract and technically can still die and have severe disease, but your chance is much less, right? So it's not necessarily the timing of your infection, but your vaccination really that matters in this case. Okay.
And I have a question here, Dr. Lachan. And I want to go back to the issue of blood clotting, and I know that you, in one of the slides, you did make reference to it. But again, sometimes when we get an explanation on, for example, blood clotting, you get the same questions being asked over and over again, and maybe it's a good idea to repeat, and to give a response as much as possible. And the question is, what blood clot signs should someone be looking for after getting a COVID-19 shot?
I think it's generally feeling unwell, pain in your abdomen, pain at any site in that area, nausea, that kind of thing. And usually that can occur anywhere between 4 days and 4 weeks post-vaccination. So, and of course, difficulty breathing, that's a big one too, right? If it's a blood clot that's moving through your system and getting into your abdomen, because the areas are different. If it's a CVST, which is the cerebral one, the venous sinus thrombosis, then of course you'll get dizziness. That kind of stuff is much more severe. You get like stroke-like symptoms and those kinds of things. So it really depends on the type. You can also get, of course, myocarditis with the Pfizer and the Moderna, which is shortness of breath, pain in your chest, basically, because it's hot. It's almost like a hot cardiac condition that's happening when you get those particular severe serious adverse effects with Sinopharm and Sinovac and some of the inactivated whole vaccines. You get a condition like encephalitis, which we see with a lot of the other types of vaccinations like MMR and those kinds of things. You can get that. That's a normal, not a normal, but a very rare serious adverse effect that can occur basically with all vaccinations across the line. And also you can also get clots. It's just that it's just seen, and I always tell people these things are relative, like how they stopped Johnson & Johnson and AstraZeneca. They didn't stop Pfizer and Moderna. And
Yes.
Pfizer and Moderna showed the clotting in the clinical trials at 4 in a million and 5 in a million, which is much higher than Johnson and Johnson and Johnson. So a lot of this stuff is political. So we have to take these things with a grain of salt because, if you're in a country that's producing the vaccine, you're going to stop it because that's going to stop your ability to be able to vaccinate your people and that kind of stuff. So it's happy for them. They have all too happy. The United States is all too happy to say, well, we're stopping that, but we're not doing this and we're not doing that based on their own interpretation. So every country has to kind of look at the data. And yes, you can use WHO recommendations, but you have to be aware of your demographic, most importantly, your risk of your population. Trinidad, we have a lot of individuals with severe comorbidities, right? We have NCDs coming through, in every demographic, right? Obesity is a big problem we have in Trinidad, and people don't talk about it. And that is a comorbidity. It's not even listed in the Ministry of Health as a comorbidity. I don't know why, because that is one of the biggest comorbidities around the world. It's right in your little check form. So those are things that we have to be pushing. That is the kind of stuff we have to be pushing people to do. You should vaccinate because you have all of these different risks. So less so much the adverse effects, the 1 in a million, the 4 in a million, the 5 in a million clotting risks that we see, and much more of you have a 1 in 50 chance of dying of COVID-19 infection if you have obesity. You have a 1 in 25 chance of dying if you have cardiovascular diabetes. That's the kind of, and if you have lung disease, I think it's almost like 1 in 25. It's very, very high risk.
Yes, interesting. Dr. Ramlashan, we seem to be getting a lot of questions coming in, even at, as we were as we were talking. And it's interesting that you mentioned, the word politics. I got a question here that came in from one of our viewers, and the person says, I'm not sure if this is taking you out of your comfort zone somewhat, but the person says, can you comment on PM or Prime Minister Boris Johnson's lifting restrictions and letting citizens take personal responsibility on their safety?
I mean, I could just comment and say, it's up to the regulations in the country that you live. Basically, that's what Trump did in the 80s in the US. They didn't have any restrictions in a lot of the country, because he decided that he wouldn't do it. So again, it just depends. And then Sweden, went the way of doing herd immunity naturally, initially. So a lot of people are lifting restrictions based on the economic situation and the socioeconomic situation because they're tied together very closely. And a lot of people are looking at risk and saying, okay, well, Canada says, we're not going to open up until we see 75% immunity, right? Other countries are like Seychelles and so on opened up kind of early. They had 62 and they thought they were good, but they clearly weren't because they got a big surge. When the variants arrived, and because they still had a large enough unvaccinated population to die and get severe disease and death, and that's what they saw. Now they didn't see anybody who was doubly vaccinated dying, which was great, but and a good advertisement for Pfizer and Sinopharm because that's what they had in that population. But there's pros and cons with opening up too early. And you really have to make that decision as you see fit.
Yes, and I guess each country and each region would have their own unique.
They should take technically the government should be run by the people and should go with the people's views because some people are very much lockdown, and some people are very much in terms of the population no don't open up. Look at the US now, everybody's walking around without masks. Look at Europe. All the football games, thousands and thousands of people.
Back. Yes, we've been seeing
without masks, jumping up and down, cheering for their teams. Cricket, we saw it too. You're gonna see that, and so it really depends on the region. It really depends on their situation. We might get to a point where people are going to ask for testing prior to these events, like the antigen testing, the little quick tests, and so on, which will kind of give you an idea. Just like what we're seeing with international flights, people are asking for RT-PCR before flying. They might be forced to quarantine, those kinds of things, but more and more people are going to open up over time.
Yes, okay. I have another question coming in here from Mark West. The person says, given the rise of the Delta and Delta Plus variants, how can we in Trinidad and Tobago best protect ourselves?
Vaccinate. Get vaccinated as fast as you can. If you are offered it through these little mini herd groups. For example, if you're in the energy sector, if you're a teacher, if you are involved in the supermarkets, that kind of stuff, construction, manufacturing, all these individuals who've gotten these pockets, get vaccinated. Do not hesitate. People who are older, over 60, are being vaccinated anywhere in Trinidad and Tobago right now. People with comorbidities, I think, have to be entered by the clinics that they're in or something to that effect. But go through whatever pathway that is available to you to get vaccinated, and wear your mask and socially isolate, socially distance. I mean, we don't have to get to the point where we are locked down forever, because we're going to have to live with this. I always mention this in all of my talks. This might be a 20 to 40 year. It took us 40 years to eradicate 200 years to eradicate smallpox.
Oh, yes.
Right? We did it 40 years ago, but it took us 200 years. Of course, we have our tools a little bit better now, so hopefully it's not going to be 200 years, but we're going to have to live with this. We're going to have to live with it. And the way to get out of it, countries with vaccines have to spread it to the rest of the world. And that's where the politics come into it. You can't take 500% of the vaccines and hoard it like Canada and don't give anybody. You're almost at 70% vaccinated. Okay, all right, now it's time to kind of give it out because you've gotten enough.
Well, the United States president, I think, is echoing those same sentiments, and the U.S. has been talking about sharing the vaccines. And,
yes, they've been talking.
Less, of course, again, maybe the politics,
they've been talking.
is very much present. And we have two more questions coming in, but before those two questions, Dr. Ramlachan, I have a question as well. With what is happening in terms of the virus and its spread, and with respect to Trinidad and Tobago, do you feel that there is going to come a time when there is going to be legislation? Because as we have it, our laws in Trinidad and Tobago, if we look at the OSHA laws provisions, if we look at when we talk about public health and safety, do you believe that there would come a time when we may move towards legislation where vaccination specifically for COVID-19 is concerned, if we have a situation where the vaccine hesitancy increases, because there are a significant amount of groupings within the country who believe that that they should not be forced into any kind of vaccination program?
Well, it's ironic because you can't go to school on a Ministry of Health, Ministry of Education, public school without your vaccination card. You can't graduate from university.
But there's nothing specifically for COVID-19.
Well, what I'm telling you is we're used to it. We have mandated vaccinations all our lives. So why can't COVID-19 become part of the mandated vaccinations? I don't understand. That's something that I cannot relate to at all, because it's something that's mandated. We can't fly to Suriname. My husband worked in Suriname offshore. He couldn't fly without his yellow fever vaccination on his international immunization card. This is something that we are very accustomed to. We are a country, Trinidad and Tobago in particular, that has been very adherent to vaccinations. We have one of the highest uptakes per capita in the world of vaccines. Everybody lines up at the pediatrician with their 3-month-old getting their vaccinations. And right now we give a 6-valent. I was shocked to find out when I had my daughter, she had to get a 6-in-1. I was like, what? We can't break it up. We can't spread it out. And they're like, no, that's what we do now. Take it. And I was shocked. And I was like investigating, and should I break it up? And because, I, as an immunogeneticist, I know what it does to their immune system.
Yes.
And I was very concerned. But if you ask a regular person on the street, number one, they don't even know it was a 6-valent vaccine. Number two, they don't even know the brand or the manufacturer of the vaccine. And number three, they go with the doctor's recommendation and when those booster doses have to be given. If they tell you have to get 3, they say, okay, write it on my vaccine card. I come in when you tell me to come. Why is it so shocking that we have to take 2 doses of COVID-19 vaccine and we might have to get a booster in 6 months or 12 months? I don't understand. It's something I cannot relate to, Mr. Cummings. I'm sorry. But I believe that vaccine regulations are coming. Mandatory vaccination is going to come for COVID-19. It's already come in certain parts of the world.
Yes.
Certain parts of the world, you cannot be employed in certain government agencies.
Especially for the traveling industry.
Well, yeah. I mean, you can't enter somebody's borders if you're not vaccinated into certain countries, and they've already been mandating it. California has already done it. They've said that employers can mandate for employment for current and future employees have to be vaccinated if they want to. It's part of their law. I believe Trinidad is going to have to go in that direction at some point, as we have with all the other vaccinations that we insist that people get in this country. And I think people are just going to have to get a buy-in. I think as time progresses and people become more familiar with it,
And a little more educated, a little more informed.
and sadly, as people become more familiar with people who've died because of it, because sometimes that's what you need. You need to see, you need to have that shock effect.
Yeah.
You need to have that shock effect. Well, you know, I know a girl who, one of my friends told me, one of her students lost her two grandparents, her mother and her brother, in the last year of COVID-19, and still had to write exams this year and sat down and wrote her exams.
Yes.
There are individuals like that and stories like that coming up over and over and over again in this country. This is not something just that we see on TV now. When we saw all those people,
it has come home. Yes.
Yeah, those people upside down in the ventilators in Italy and France and the UK and US last year, we were like, oh gosh, look at that! Wow, you know, we don't have that here. Well, guess what? We have it here. So people have to start embracing that.
Indeed, Dr. Ramlachan, I know that we are closely, you know, at the end of the session, but I wanted to get two questions in that came from the viewing audience, and I would pose both of them at the same time, and you can respond to them individually. And the person says, this person is Cyrus the virus here. What would nerve damage risk after? What about nerve damage risk after taking the vaccine? And the other is, what about people with epilepsy and one kidney? What are their risks to be vaccinated?
Well, I don't know whether or not that specific type of individual was included in the clinical trial, because that's a very specific case, right? For somebody to have epilepsy and one kidney. I can tell you that people with comorbidities were included.
Yes.
Yeah, but I mean, I get these things all the time. But I generally speaking, people with comorbidities were included, right? So if you've had an immunocompromised situation, as in you have one kidney or you on dialysis, you have kidney disease, those people were included, and they actually benefited from the COVID-19 vaccine. Even HIV positive people who are on chemotherapy, long haul cancer people, cancer patients who were in remission or even in between chemotherapies were advised to take the vaccine. Epileptics and immunocompromised people are also advised. The only issue becomes if you're taking immunosuppressive drugs. So people who have had transplants, those kinds of things, people who are on chemotherapy and things that suppress your immunity and high corticosteroids, and you will not get as good a response, but you might still get a protection, a level of protection. So people are saying, consult your doctor, make sure that you're okay to take it. And if you have any of these conditions, to take it, because it is much better to have some level of protection than none. That's the idea behind it, right?
Right. And there's this question, and I think you answered this already, Dr. Ramlachan, in your presentation.
I did,
This particular one just came in. I think you also responded to this question. Depending on, the person says, depending on the vaccine availability, what are your views on mixing vaccine doses? I think you addressed that in your presentation.
The clinical trials are showing positivity, very high immunity, as much higher actually than they expected. From mixing doses in certain countries, and that's actually been the recommendation already. So Germany in particular and Canada are now mixing vaccines exclusively. So they're getting one AstraZeneca and one Pfizer and one AstraZeneca. I know the UAE and Bahrain are also recommending booster from Pfizer after Sinopharm, 2 doses of Sinopharm followed by a booster Pfizer. And a booster of AstraZeneca, depending on which country it is. I always get mixed up which one is doing which, but they have already implemented those kinds of things. So we're going to see that. We're going to probably get a point where 6 months from your first, from your second dose, I should say, they might say, okay, well, you need to do a booster. We have these available, come in and get your booster shot a year from now. Because remember, this is an evolving thing. Yes. We do not know how long immunity is going to last. We started testing these back in June, July, phase 3 trials, right? So we know from those individuals who got those vaccines then to now, as in 12 months of data, because that's all we have, immunity lasts, right? But we don't know much about the real life data until it comes in. And as it's coming in, it's showing that people over 60, for example, with Sinopharm, we need to watch their immunity. If it wanes, they need to get a booster. those kinds of things. That data is coming in now slowly.
Okay.
And we know that to be factual because remember, some of these vaccines weren't tested in these demographics. Sinopharm was only tested clinically between 18 and 60. It was not tested in the phase 3 trials post 60. So we are counting on real world data for Sinopharm. Same thing with breastfeeding and pregnant women. It wasn't tested in those populations, but now we have real world data that shows that yes, most of these vaccines are effective and not harmful and should be taken, right? So.
All right, Dr. Ramachan, I think I'm afraid we're out of time. And before we end, though, I just wanted to give you about a minute or two just to give some closing remarks on this very important, session treating with the myths and of COVID-19 vaccines, etc. In our closing moments, can you just give us some closing remarks before?
I mean, it's been a pleasure and a privilege to be able to come to the public through UTT's encouragement and support through this Hyper Hope series. This has been well supported by the President's Office, Gansham Mohammed, Corporate Com with Sandra Canese, and these individuals who have helped with this and development of this whole program and how we approach it. And kudos to UTT for allowing me to do this and being on board and supportive as we try to educate the public. And this has really been a privilege, as I said, and it's been a lot of fun because I don't usually get to spout science so much, right? Except when I'm teaching, and then half the times people sleeping and not paying attention. Some of y'all probably still sleeping, but that's okay. We've been getting a lot of good feedback, and that has been really, really, really heartwarming. And people have actually told me that what we have said in these sessions have actually changed their minds, and they are no longer vaccine hesitant, and they've gone to get their vaccine. And that has just, been mind blowing to me because I appreciate that that change of heart, and it comes from analysis, it comes from education, it comes from understanding, and it's been a privilege to be part of that. So our sessions are on IETV being repeated. They are recorded, I guess, in perpetuum here on YouTube. You can access them as long as they're up. And you can access from session 1. And we're having a couple of standalone sessions dealing with mental health, non-communicable diseases, and long-haul COVID, which are specific topics that we've been asked to do kind of like a panel discussion. So we're going to do that and announce those dates later on. But again, thank you for the audience for being, fangirls and fanboys. I have gotten a really, really good positive responses from this generally. The hardcore anti-vaxxers are always going to be hardcore, but with education, we can
mitigate some of those.
We can negate it, and we can increase vaccine hesitancy. We don't need 100%. I always tell that to everybody. I will be happy with 75%, right? Okay. The last 25% we'll work on through mandated legislation and other kinds of things. But if we can get 70%, 75%,
in a relatively safe zone,
we're going to be in a good place, right? And we need to defeat those variants. We need to get rid of them. We need to get them out. We need to keep them out of our house. And this is the way. Vaccines are the way. And we need to embrace that. Thanks again.
Dr. Ramachan, I want to thank you so much for spending the time with us for the last hour and a half, and going through that very clinical presentation there and explaining to us about this whole business of vaccine, the topic Hope or Hype, investigating the COVID-19 vaccines, and looking at efficacy, and just going into some of the areas that and answering and responding to some of the questions that we got coming through from our viewing audience. And I want to thank you again for the time that you have taken, and I believe that we would have to we'd have to continue these sessions in some formats, some ways. There are lots of other areas that we need to touch on. And again, I want to thank you for taking the time to sit with us at this time.
And thanks so much for moderating for us on short notice. Really appreciate it. Fantastic job.
Thank you. Dr. Nicole Ramlachan, Associate Professor of Biotechnology, UTT, who was talking with us there for the last hour and a half on the topic Hype or Hope, investigating the COVID-19 vaccines and dealing with a lot of the myths there. Dr. Ramlachan, as I said, holds a PhD in genetics from Texas A&M University, USA, and BSc and MSc from the University of Guelph in Canada. Guelph in
University of
Canada.
Guelph, yeah.
Yes.
Don't mispronounce it, people, because I'll
Yes.
get all the alumni who listen will
Yes.
be like,
Well,
"How
you've said
can
it.
you not say that?"
You've said it. Yes. You've said
No,
it.
it's one of those hard words, but it's Guelph.
Yes, and thank you again, Dr. Ramlachan, for guesting with us. Thank you.
Thanks so much for being here. Thanks so much